So hello everyone, thank you for joining us. We'll start in 5 minutes from now. So hello everyone, for those who joined now, we're gonna start in 5 minutes. Okay, 5 minutes and 3 minutes, and we will start the event, inshallah. So Dr. Rayo and Dr. Dima, how are you today?
I'm doing
Very
well.
good.
Oh, go ahead, Dima, sorry.
So Dr. Rayo,
Happy to be here with you.
Thank you. Dr. Rayo, what's your time now?
It's 12 o'clock actually.
Okay, so it's noon now.
Yeah, time of lunchtime here actually.
Yeah, and it's dinner time here. It's 7 p.m. now, Beirut time, and it's 8 p.m. In KSA time. And Dr. Dima, what's your time now at your zone?
So now I'm in Florida, Orlando. So it would be like it's 12 p.m. as well.
Oh, okay, so it's the same time.
Yeah, so I'm traveling now. I'm not in Jordan, so that's why.
Okay, that's great. Okay, so we're gonna give 2 more minutes for more people to join us. And then we can proceed. And we have Dr. Tantawi. Dr. Tantawi, how are you today?
Alhamdulillah, I'm fine. How are you doing, Dr. Fatima?
Very good, very good. We're glad to have you with us, Dr. Tantawi.
Thank you, you too.
Thank you. Okay, great. So we're gonna start. So good evening, good morning, doctor colleagues who are virtually connected. We are delightfully welcoming you to our second IVPN educational journey in 2020. Throughout this platform, we will share the latest evidence-based oncology pharmacy practice, learn from our professional experts, and aspire our daily pharmacy practice. Today, our session, it's gonna be targeted, and we're gonna talk in depth about the treatment options for testicular cancer with our professional expert, Dr. Rayo Rajan, and having our dear colleague, Dr. Dima Baba, as our moderator. I would like to share with you that the Q&A section will be active throughout the event. So please free to submit your questions. You can write your name, your job position, and at the end, Dr. Dima will share your questions with Dr. Rayo. And in case we missed any, don't worry, we'll be sharing your answers later via the email you have already registered during the event. So with no further delay, it's my honor to introduce Dr. Dima. Dr. Dima earned her PharmD degree from the University of Jordan in 2012. She nourished her working experience by working in both private and public sectors as a clinical pharmacist in different pharmacy sections, inpatients, outpatients, and clinical floors. Her interest in oncology developed when she started preparing IV chemotherapy in 2013. As one of her tasks as a junior pharmacist, inpatient clinical pharmacist in one of the private hospitals in Amman. After that, Dr. Dima pursued her master's degree in cancer and therapeutics in Queen Mary University of London in 2015. She realized that her passion to oncology started to grow more and more and went back to Jordan to be an oncology clinical pharmacist and controlled drug accountable officer. In 2021, Dr. Dima gained her board certification in oncology to accomplish another milestone in her career. She is a co-editor in Oncology, the IVPN Oncology newsletter, and a member of the organizing team in IVPN Oncology. As well, she is a dear friend to all of us. Dr. Dima, it's an honor to have you with us. With no further delay, the mic and the floor is yours. Thank you.
Thank you so much, Dr. Fatima, for this beautiful introduction. Let's head for this presentation. I'm sure it would be really interesting and fruitful. But first, I want to thank each one of you, our respected audience, for always trusting us with your valuable time and being here with us today to attend this webinar with the title Testicular Cancer Review of Treatment Options. Before starting, I want also to thank IVP Oncology core team members and our leader, Dr. Fatima, of course, for their effort in organizing such activities. We all know that without their effort and their passion and commitment for this lessserv, we won't be here tonight attending this fruitful webinar. I'm super happy today to introduce one of our core team members, and the speaker of today is Dr. Rayo Rajan. Dr. Rajan is a board-certified oncology medical information specialist at Med Communications and a clinical staff pharmacist at Luminous Health and Arnedale Medical Center in Maryland, USA. He also served as a co-editor for the Oncology, the IVPN Oncology newsletter, of course. Rayo received his PharmD degree from Howard University College of Pharmacy in Washington, D.C. in 2012. He had also received his antibiotic stewardship certificate from the Society of Infectious Disease Pharmacists. During his professional life, he had served as a preceptor to many pharmacy students. He is passionate about patient education and their well-being. In his spare time, he enjoys playing cricket and spending time with his wife and lovely 2 kids. With no further delay, I would leave the mic to Dr. Rio to start the talk. I would encourage you all to participate by sending your questions and comments through the Q&A box so we can address them after the presentation. Please, as Dr. Fatima said, for better discussion, send your name, your position, and your answer so we can do a better discussion. Thank you, and Dr. Rio, the mic is yours.
Thank you, Dima, for the kind introduction. Let me try to share my screen here. Yeah, let me know once you can see the presentation.
Yeah, we can see it.
Okay, thank you. So in the next hour, we'll be discussing about the various treatment options in testicular cancer. This is the agenda for today. I'll be going over epidemiology and trends of testicular cancer. We'll briefly explain risk factors, classifications, various treatment options, and we'll also go over supportive care and management. Before I begin the discussion, I want to let you know that I have no conflicts of interest to disclose. The topics I'm going to discuss here in this presentation are my viewpoints only, and it does not represent the view of my opinions of my employer. We'll begin the discussion with epidemiology, then trends and risk factors. So as far as testicular cancer goes, it is not a common cancer in males, and it occurs in about less than 1% of all male cancers. However, it is a common cancer in young men. Estimated cases in the United States is closer to about 10,000 and has a lower death rate. Death rate in 2022 was about closer to 500. The relative survival rate has been about 95%. And what this means is that 95 men out of every 100 men diagnosed with testicular cancer will live at least 5 years after diagnosis. Testicular cancer is a cancer that can be cured in majority of the cases. As you see, the median age is about 33 years. It could occur in elderly population as well, but frequently between the ages of 20 to 30. This is a graph showing the trends and death rates in the United States. As you can see, the new cases has been slowly decreasing, and the death rates has been steady for a while. This is a graph that is showing what stages testicular cancer is being diagnosed, and the stages is being compared to a 5-year relative survival. You could see here is that when testicular cancer is diagnosed at an early stage, about 68% of them are diagnosed at the early stage. The 5-year survival rate becomes 99%. Once it gets to the lymph nodes, it becomes about 18%, and the 5-year survival rate becomes about 96%. And once it has started spreading to various parts of the body, including liver, lung, etc., the percentages kind of goes lower. It's about 73, and about 12% of this cancer is diagnosed at this stage. So what are the risk factors of testicular cancer? As you can see, undescended testicle could be a risk factor. Normally, the testicles develop inside the abdomen of the fetus, and they go down into the scrotum before birth. The risk of testicular cancer might be a little higher for those men whose testicles stayed inside the abdomen, as opposed to that one has descended at least partway. Also, having a family history can also play a role. Having a father or a brother with testicular cancer may increase the chances. Also, age is also a factor, as you know, about half of the testicular cancer occurs in early men, about like 20 to 34 years of age. However, as I said, this can also affect like elderly men as well. As far as HIV infection goes, there is some evidence that men with HIV, particularly with AIDS, may be at an increased risk. And finally, race. White men have an increased chances of getting testicular cancer as compared to Asian and Black men. We'll now go into the symptoms of testicular cancer. As displayed, these are the symptoms of testicular cancer on the slide. At times, testicular cancer could be misdiagnosed, as some of the symptoms could be non-specific. For example, a pain or a discomfort in a testicle could be diagnosed as epididymitis, where you could be prescribed a course of antibiotic. Most often, the first symptom of testicular cancer is a lump on the testicle, or the testicles become swollen or larger. Some testicular cancer tumor might cause pain, and also you could have a feeling of heaviness or aching in the lower belly or scrotum. We'll now go into the classification, diagnosis, and staging. So testicular cancer is a cancer of germ cell tumors, and germ cells are those cells that produce sperm in men. And about 90% of testicular cancer arise within these germ cells. So testicular cancer can be divided into two different categories. Mainly is the seminomas and the non-seminomas, where the seminoma is divided into classic and spermatocytic. Majority of them, about 95% of them, are classic seminomas, and the spermatocytic seminoma usually occurs in elderly men. As far as non-seminoma goes, it is divided into 4 different categories. As you can see, they get their names from how they look. For example, the yolk sac, carcinoma cells, they look like yolk sac of an early embryo. In the United States, majority of the cases are seminomas, ranging from about like 55 to 60%. And also seminomas tend to grow, grow slow and spread slowly, and they're less aggressive, whereas the non-seminoma are the ones that's more aggressive and grows faster. As far as the so how do we diagnose testicular cancer? For diagnosis, what the doctors usually do is that they'll do a physical and a history of the patient, which is followed by an ultrasound. If they see a mass for the ultrasound, then it's followed up with serum tumor markers or like blood test, and which is followed by surgery. And so for further staging, there's more imaging that's done, which is like CT scan, MRI, etc. Tumor markers play an important role in the diagnosing and staging of testicular cancer. They are assessed via blood test before and after surgery, and also throughout the therapy. There are 3 tumor markers that are monitored in testicular cancer. They are the alpha ferroportin, or AFP, which is a serum protein produced usually by the non-seminoma cells, and it's usually elevated in non-seminoma, whereas not in seminomas. Also, the lactose dehydrogenase here, or LDH, which is a non-specific biomarker used for diagnosis. What that means, that it gives an idea of how widespread the disease is. So you don't usually diagnose it just by the number. Whereas the HCG is a hormone that's usually not found in men. It's usually, it could be elevated in both seminoma and non-seminoma. I've provided here the numbers, the normal numbers of these biomarkers just for your reference. Moving into one of the surgeries that's performed for testicular cancer, it's a radical inguinal orchiectomy, which is a surgery to remove testes. This is performed after ultrasound and tumor markers are collected. This is a gold standard for diagnosis and initial management of suspected testicular cancer. The surgery could last about an hour. Usually, as a same-day surgery where the patients can go home. And as you can see, the incision is made around the groin area. I'll now go into the staging of the testicular cancer. The staging is based on the American Joint Committee on Cancer, the AJCC. TNM staging system. T, as you know, stands for tumor, N for nodes, and M for metastasis. Also, the testicular cancer incorporates serum tumor markers also into the staging, which is unique to testicular cancer. Also, clinical category as well as pathological category is also used in the staging system. This is just for your reference only. You could read more about in the guidelines. I just wanted to show how elaborate the staging is performed in the testicular cancer systems. Usually has 4 stages, with different substages. Where something like M0 means that there is no node involvement, M0 is no metastasis, and S0 meaning that where the serum tumor markers are normal. This is a more simplistic and visual approach of the staging, where you can see is that stage 1, where the cancer is confined to the testicles only, and whereas in stage 2, it starts to spread to your lymph nodes. Basically, your retroperitoneal lymph nodes, meaning that around the abdominal area. Also in stage 3, it starts to spread to other organs, including liver, lungs, and sometimes the brain. So I'll start reviewing the treatment options for seminoma now. So stage 1B seminoma, after the staging is completed with the surgery, the preferred approach is usually surveillance. What surveillance means is that the doctors will be performing history and physical abdominal imaging, abdominal CT scans, etc., every couple of months to make sure that the patients are not progressing. About 15 to 20% of patients who undergo surveillance may relapse. Therefore, the alternate options include you could do radiation, or you could do chemotherapy with carboplatin with 1 to 2 doses using a target AUC of 7. So when you compare radiation to chemotherapy, so what's the preferred approach? I've shown you the Calvert equation showing how to calculate the target dose of carboplatin with a target AUC of 7. The maximum dose is given is about 1,050. The renal function, the creatinine clearance is capped at 125 ml per minute. The other option is to give radiation. When you give radiation, you're giving a total dose of 20 gray of radiation. So a gray is a unit for radiation. And you're giving it in 10 fractions of 2 grays, meaning that the patients will be getting 2 gray of radiation during every treatment section. So they'll have about 10 treatment sections to attempt to complete the regimen. So Oliver and colleagues did a comparison of the 2 therapy approaches, where they compared carboplatin versus radiation. And what they found is that they could not find a difference between the relapse-free rates for carboplatin versus radiation. And they concluded that a single dose of carboplatin is non-inferior to radiation in reducing relapse. So either approach is fine. The decision to administer radiation or chemotherapy could be tailored based on the patient's need. As far as stage 1S goes, it's usually that staging is usually uncommon to see. It comes with a persistent elevation of tumor markers after orchiotomy, and the treatment of choice is adjuvant radiation. And moving into stage 2A seminoma. So as far as stage 2A seminoma goes, your lymph node size is usually measuring 2 or less in diameter. Either chemotherapy or radiation is preferred. Chemotherapy is given, patients usually get etoposide and cisplatin, or bleomycin, etoposide, and cisplatin. We'll go into both the options pretty soon. As far as stage 2B goes, that's when your lymph nodes are measuring anywhere between 2 to 5 centimeter in diameter. Chemotherapy is the preferred option here, with either BEP or EP. Radiation is also offered if patients have non-bulky disease, meaning that the lymph nodes are 3 or less than 3 in centimeters. Diving a little bit deeper into what BEP regimen means. So BEP consists of bleomycin, etoposide, and cisplatin. The P in this regimen comes from the brand name for cisplatin, which is platinol. This is a regimen that's repeated every 21 days for 3 cycles. The doses are displayed here for your reference. As far as etoposide and cisplatin goes, the only difference between the 2 regimens, BEP and EP, are that this regimen is done for four cycles, and it does not contain bleomycin. We'll now review supportive care and monitoring parameters for both the regimens, which is etoposide cisplatin and bleomycin etoposide cisplatin. Both of these regimens are classified as a having high emetic risk. What that means is that this has a potential to cause nausea, and there's a high potential to cause nausea and vomiting. Therefore, a 4-drug regimen, as shown in this slide, is recommended for as far as anti-nausea medications goes. For bleomycin, as it can cause anaphylactoid reaction, pre-medication with Tylenol is recommended. Signs and symptoms of an anaphylactoid reaction, includes fever, wheezing, etc. Pre and post hydration with electrolytes is recommended for cisplatin, as it can cause electrolyte imbalances. What I've shown you in the slide is an example of how hydration is done. For cisplatin, it differs from various institutions, maybe at your institution it is done in a different way. This is just from the guidelines. Other monitoring parameters include, this is a regimen that has an intermediate febrile neutropenia risk. And what that means is that, by giving this chemotherapy, sometimes it can lower the immune fighting power of the patients and make them prone to an infection. And so since this regimen has intermediate risk, what that means is that whether to give granulocyte colony supporting factors are based on whether patients have certain risk factors. And those risk factors are prior chemotherapy or radiation, renal dysfunction, liver dysfunction, etc. And if patients are greater, any of these risk factors, actually greater than one of the risk factors, then you can consider giving granulocyte GCSS support. So it'll be either filgrastim or pelfilgrastim, or any of the biosimilars that's available at your institution. And some of the labs that should be ordered when starting this regimen include CBC with differential, ALT, AST, serum creatinine, etc. As far as bleomycin goes, pulmonary function test must be ordered before starting this regimen, as bleomycin can cause pulmonary fibrosis. Also, potential dose adjustment needs to be done based on renal dosing. For etoposide, liver function and renal function needs to be monitored. And once again, for cisplatin, electrolytes and renal function needs to be monitored. It can also cause peripheral neuropathy, ototoxicity, and a hypersensitivity reaction. So when should etoposide cisplatin becomes a preferred regimen versus bleomycin? And like in what kind of patient population? So let's say if a patient has a reduced or borderline GFR, they should not really be getting a bleomycin, as bleomycin is cleared by the kidneys, and a reduction in clearance can increase the possibility of pulmonary toxicity. And patients with age greater than 50, as in elderly patients, the renal function tend to decrease. People with COPD and other lung diseases can cause that can cause a reduction in the pulmonary function. And some oncologists do prefer not to use BEP in patients who are heavy smokers, because as they have their pulmonary function may not be that great at times. So moving into treatment for stage 2C and stage 3 here. So it's based on classification by the International Germ Cell Cancer Collaborative Group. They classify this advanced disease seminomas with either good risk, intermediate risk, or poor risk. The classifications or the criteria for diagnosis are given in the slide. There is no poor risk seminoma. There's no poor risk seminoma as such, as seminoma is very sensitive to chemo and radiation. So the treatment options for a good, so stage 2C and 3 with good risk seminoma is treated with either EP or BEP. And stage 3C and stage 2C and stage 3 with intermediate risk is treated with BEP times 4 cycles, or which is a category 1 recommendation, and could be, or with VIP times 4 cycles with this NCCN category 2A. Giving you more details on what VIP, the VIP regimen is. Of course, VIP doesn't stands for very important person in this regimen. This is a little more toxic regimen, where it comprises of etoposide, ifosfamide, and cisplatin. The name for the V for etoposide in this regimen comes from, as etoposide is also known as VP16, so that's where the name comes from. This is a 21-day cycle with, so this is a 21-day cycle with total of 4 cycles. And Mesna is administered with ifosfamide to prevent hemorrhagic cystitis. What I've shown is, here is an example of how Mesna is administered. Again, Mesna could be administered with various regimens from institution to institution. This is just an example. In this case, about 60% of the ifosfamide dose is administered as the Mesna dose. There are institutions where 100% of the Mesna dose is also given. What are the supportive care and monitoring parameters we need to look out for this regimen? This regimen carries risk of high emetic risk. Therefore, scheduled and as needed anti-nausea medications should be ordered. GCS, the febrile neutropenia risk for this regimen is very high, and therefore GCS of support should be given. Pre and post hydration with electrolytes should be given with this regimen, as this contains cisplatin as well as ifosfamide. For ifosfamide, albumin levels should be monitored. As well as renal function, as lower albumin levels could cause neurotoxicity. Some of the labs that needs to be ordered are similar to the ones in the previous regimens, which is including CBC with DIF, AST, ALT, etc. And MESNA should be given to prevent hemorrhagic cystitis with this regimen. So what is hemorrhagic cystitis? So it is a bladder condition that can cause pain and blood in the urine when ifosfamide is given. And so how does ifosfamide cause this condition, right? So ifosfamide is broken down into a neurotoxic product called acrolein, which causes hemorrhagic cystitis. And so how does MESNA stop or prevent this from happening? So MESNA is usually given IV, and it usually initially gets deactivated in the bloodstream. It is reactivated in the bladder once filtered through the kidneys and concentrates in the bladder where MESNA detoxifies acrolein. So moving into follow-up after giving these chemotherapy regimens for stage 2A, 2B, 2C, and 3, what happens after chemotherapy is finished for these patients. Usually a CT scan is done with the serum tumor markers, and based on that, if the tumor markers are normal and there is no residual mass, or if the residual mass is less than 3 centimeters based on the imaging, then patients can do surveillance. Surveillance will include, again, more scans and monitoring the levels within certain during the initial stages. Also, if the residual mass is greater than 3 centimeters and the patients have normal tumor markers, what happens is that PET or CT scan is obtained greater than 6 weeks after chemotherapy. And if the PET scan is negative, surveillance is recommended. So what happens if the PET scan is positive? So you could do additional surgery where lymph node dissection is done. And if it's an incomplete resection and the histopathology is positive, or there is progressive disease, meaning that the tumor markers are rising, or you see there's a growing mass in the PET scan, 4 cycles of TIP chemotherapy or VEIP chemotherapy is recommended. We'll go into the details of the therapy in a minute. And so if it's a complete recession and histopathology is positive, what happens is that you'll get 2 cycles of the below mentioned chemotherapy in this slide. So what is RP-LND? It is a surgery. So it stands for retroperitoneal lymph node dissection. It is a surgery to remove lymph nodes. As you can see in this diagram, these lymph nodes are found in the area between your kidneys, along the inferior vena cava and the aorta. When testicular cancer metastasis spreads, so it usually goes first to these lymph nodes. This type of surgery is recommended to be performed in high volume centers, meaning that like a surgeon who does this on a regular basis. And a nerve-sparing approach is recommended to preserve ejaculation function. Going into what TIP chemotherapy is, it consists of paclitaxel, ifosfamide, and cisplatin. The doses are mentioned here. It consists of 4 cycles every 21 days. Supportive care for this regimen are similar to the other regimens I have talked before. So I'm concentrating here on some of the pre-medications that needs to be given for paclitaxel. It can cause hypersensitivity reaction, and some of the symptoms are anaphylaxis, hives, throat tightness, and hypotension. So therefore, pre-medication needs to be given for this regimen, which includes an H2 antagonist could be famotidine, H1 antagonist, diphenhydramine, and steroids, which is dexamethasone. So no additional dexamethasone is necessary as a part of the emetic regimen on day 1 if dexamethasone is given as as a pre-med for before administering Taxol. So VIP regimen here consists of vinblastine, ifosfamide, and cisplatin. And similar to other regimens, this is also consists of 4 cycles every 21 days. The management is similar to other regimens as far as supportive care goes. So these regimens that I mentioned are high emetic regimens needing GCSS support. So I'm only focusing here on vinblastine for this regimen as far as supportive care goes because it's similar to other regimens. Vinblastine is it's the vesicant, so it can cause tissue necrosis. Therefore, central line administration is preferred for this medication. It should only be administered as an IV mini bag in adults, as other routes can cause death. For example, administering via intrathecally. If tissue necrosis occurs and a local injection with hyaluronidase injection can be given, and heat can also be applied. What I've provided in this slide is how the follow-up regimen for advanced seminoma looks like. The follow-up involves scheduled history and physical, tumor markers, and CT scans, etc. During the first year, there is more frequent follow-up, and the interval widens if the disease does not relapse. And MRI can replace CT scan. So as you can see, the follow-up is very extensive. With this slide, I come to an end of the seminoma section, and now we'll go into the treatment of non-seminoma. For stage 1 non-seminoma after surgery, the treatment is based on the risk factors for relapse, and the risk factors for relapse include if there's an invasion of lymph nodes, spermatic cord, or scrotum. And if there is no risk factors involved for stage 1, surveillance is preferred. Nerve-sparing surgery or chemotherapy can be used as well. So if there is risk factors with stage 1, either one of the 3 approaches shown on the slide can be used. There is, when there is a lymph node invasion, there is a risk factor for relapse by just surveillance alone. So maybe in those cases, chemotherapy or surgery could be can be an option. For stage 1 seminoma, which exhibits persistent elevation of tumor markers with no radiographic evidence of the disease, chemotherapy with either a BEP or EP is preferred. As far as stage 2A treatment approaches goes, stage 2A based treatment, patients with normal tumor markers after orchectomy, they can be treated with lymph node dissection or chemotherapy. Patients with elevated serum tumor markers are treated with chemotherapy. So stage 2B treatment is based on post-surgery tumor markers and findings on imaging. If tumor markers are normal and findings on the imaging is abnormal, meaning that the metastasis is limited to lymph nodes in the peritoneum, then chemotherapy is the preferred option. In select cases, you could also do lymph node dissection. If tumor markers are normal or it is elevated, and the metastasis is not confined to the lymph nodes of the the abdominal area, then only chemotherapy is preferred. So what happens? What happens after the patients gets this treatment in stage 2A or 2B? So let's say they had they were treated with primary chemotherapy. So they were treated with primary chemotherapy and they have negative tumor markers and the residual mass is less than 1 centimeters. Then a surgery, lymph node dissection surgery is recommended. If the tumor markers are negative and there is no residual mass, or the residual mass is less than 1 centimeter, then survival is recommended. And select cases, lymph node dissection surgery is also can be used. So let's say if a patient had received primary lymph node dissection as their primary therapy, so their further treatment will be based on if the surgeon was able to find any pathological lymph nodes. If they were not able to find any lymph nodes, then surveillance is recommended. If one is found, then surveillance is preferred. Adjuvant chemo can also be offered. In pathological stage, stage 2, surveillance can be done, or adjuvant chemotherapy can be done. Adjuvant chemotherapy is preferred in this case as there is a higher chance for relapse. And in stage 3, only adjuvant chemotherapy is offered as a relapse surveillance gets up to greater than 50% in this case. Stage 2C and 3A disease is categorized based on the IGCCC classification, where it's given a good risk category based on these criteria that's outlined here. And all of this criteria needs to be met for the serum tumor marker criteria, metastasis criteria, and the origin of the tumor needs to be met for the disease to get a good risk criteria. And the treatment options are either with BEP or EP. And the cure rate is about 90% for this stage. Diving into a little bit of literature here, there was a comparison done between these two regimens, BEP and EP, in non-seminoma good risk patients. It was done by Colleen and colleagues, where they conducted a head-to-head trial comparing these two regimens. And what they found is that patients receiving 3 cycles of BEP and 4 cycles of EP, both study arms were equally balanced. The study found out that there was no differences in the overall survival for these patients. The study was underpowered to detect the difference. Lawyer and colleagues conducted a randomized trial where they compared 4 cycles of BEP to 4 cycles of EP in patients with good risk metastatic seminoma. The study demonstrated that 4 cycles of BEP demonstrated significantly better OS and DFS than 4 cycles of EP. DFS meaning disease-free survival. Patients in the EP arm had relapse from complete remission. Toxicity were comparable between the 2 regimens. However, please note that 4 cycles of EP is an acceptable option per guidelines, and 4 cycles of BEP can lead to more toxicity. Going into the treatment options for stage 3B, non-seminoma, this is a disease that is categorized as an intermediate risk disease. And primary chemotherapy is the treatment option for this stage. These are the criteria that needs to be met for someone to be classified with an intermediate risk disease. Keep in mind that one of the tumor markers needs to be met along with the metastasis as well as the primary origin of the tumor. BEP chemotherapy regimen is the preferred option, which gives about 70% cure rate. Patients are not able to tolerate 4 cycles of BEP, then VIP regimen can be offered. And Finally, we're coming to stage 3C disease, which is classified as a poor risk disease. The treatment options include a BEP for 4 cycles or a VIP for 4 cycles. Less than 50% of the patients experience durable response with this treatment options, and about 50% die from this poor risk disease. I've shown here the classification, how it's based on. So any of the criteria needs to be met for patients to get a poor risk disease category. So what happens after patients gets this chemotherapy regimens in these different categories: good risk, intermediate, and poor risk? Further imaging studies are done similar to seminoma staging. Tumor markers needs to be obtained. The patients have a complete response, then and their tumor markers are normal. Then you could do surveillance. You could also do lymph node surgery in certain cases. The patient has partial response to chemotherapy, and if the tumor markers are normal, then surgical resection can be done. The surgical resection shows necrosis or teratoma, then surveillance can be done. And if the surgical resection shows yolk sac, choriocarcinoma, etc., then further chemotherapy is offered. And if there's a partial response to chemotherapy with rising tumor markers, then patients are offered second-line treatment. Once again, I have shown you an example of how a follow-up is done for these patients. Displayed here are the intervals on like how patients are being followed up. Initially, there's more frequent follow-up, and the interval kinds of widens if the patient doesn't have any relapse in the subsequent years. So I'm moving into the second line therapy here. So let's say the patients, their disease relapse after first line therapy, and or if they don't have a durable response achieved from the first line therapy. So that's when a second line therapy is offered. Second line options include, so let's say that relapse is within 2 years of completion of the primary therapy. Usually clinical trial can be offered. Conventional dose chemotherapy can be offered with TIP or VIP. Or high dose chemotherapies are usually offered with high dose carboplatin or with Taxol, with ifosfamide, etc., and with stem cell support being provided. If the relapse is after 2 years after the completion of primary therapy, surgery is recommended. Clinical trial is also recommended, and also conventional or high dose chemotherapy can also be offered. I have listed here the dosings for the high dose chemotherapy. It's just for a peripheral understanding and appreciation of like how high these doses are. I have not administered any of this, as I have not worked at a stem cell transplant center. Moving into what happens after after a second line therapy is given to a patient. Once again, more imaging and tumor markers are done. And if patients have complete response and the tumor markers are normal, then you can do surveillance. You could also do surgery in select cases. There's partial response and the tumor markers are normal. Surgical resection of all residual masses is recommended. And if there's partial response to the second line therapy and the tumor markers are abnormal, so then the treatment is based on how the tumor markers are behaving. For example, if the tumor markers are elevated and persistently rising, then third line options could be offered. And if it's tumor markers are elevated but it's stable, then we could do surveillance. So it leads up to like what are the options for a third line therapy here? So if it's an early relapse, then enrollment in clinical trials can be considered. The patient hasn't received, so let's say the patient has received conventional dose, then high dose can be offered. Surgery is also an option here. Immunotherapy is also an option if the patients test for deficient MSI or MMR high, or if they have tumor mutation burden, testing is like positive. And if the relapse is after 2 years, then surgery is preferred. You can also give high dose chemotherapy if not previously used, or you could do palliative chemotherapy at this point. Immunotherapy could also be an option based on the testing. Palliative therapies include treatments with chemotherapy called gemcitabine or oxaliplatin. Remember that, keep in mind that these patients are heavily pre-treated and they're kind of cisplatin resistant at this point. Oral etoposide is also an option. So, so what are some of the take-home points as far as testicular cancer goes? So, testicular cancer is a cancer of the younger men as compared to older men. It has a better survival rate as compared to other solid tumors, and it is more sensitive to chemo as well as radiation here. Testicular cancer, it has a potential to cause numerous toxicities. So pharmacist has a key role in providing supportive care and lab monitoring so that these toxicities can be prevented. It is recommended to do the lymph node surgeries in a high volume center, so the surgeon is more experienced. So that's all I have for the discussion today. These are my references, and thank you so much for having me. And I just want to take this time to thank Fatima, Dr. Fatima, who is the leader of the IVPN oncology list, who has supported me and given me an opportunity to speak here to everyone. And thanks again.
Thank you, Dr. Rio, for this comprehensive and amazing presentation, actually. So let's go for the poll questions first, and then we'll take the questions from the audience. Okay, so the poll question will pop up for each one of you, so you can answer it. I will go through them. There are three questions. The first one is maximum recommended carboplatin dose using target of AUC 6 is 600, 750, 900, or 1050. The second question is NCCN preferred treatment approach for testicular cancer stage 1 seminoma is chemotherapy, radiotherapy, chemoradiation, or surveillance. The third one, actually, it's a case. I will read it and we'll give you time for the answer. AP is a 25-year male patient who has been recently diagnosed with testicular cancer. Images reveal that he has no non-pulmonary vascular metastasis. His serum tumor markers were as follows: AFP from 1,000 to 10,000 nanogram per meter, per ml, STG 5,000 to 50,000 international unit per liter, and LDH from 1.5 to 10. So I think the answers appeared. I will give you another few seconds to answer for everyone to have the chance to answer. So, Dr. Rio, if you would like to discuss the answers. The first question, which was maximum recommended carboplatin dose using target of AUC 6, is the majority, around 45% of the audience answered 750.
Yeah, sure. This is a question. I just want to make sure that you're able to see my screen.
Yeah.
Okay,
We're able to see it.
So the question was, what is the maximum recommended carboplatin dosing using target AUC of 6? Going into the answer here, so it's calculated using the Calvert formula, which is, which takes into account the renal function of the patient. It is capped at 125. GFR is capped at 125 ml per minute. So, plugging the numbers into the equation, it gives you a maximum of 900 milligram. And so the answer is C.
Yeah, so perfect. So the answer is C. 27% of the audience had it right. And this is the explanation. Thank you, Dr. Rio. So we'll go to, the second question. The NCCN preferred treatment approach for testicular cancer stage 1 seminoma is?
So,
yeah, 36% actually of the audience said radiation, and there was like a close other 2%, like a 27% for chemoradiation and for surveillance also. So
the answer here is D, which is surveillance, as you can see from the slide. Stage 1A and 1B, the preferred approach is usually surveillance. As I said, about 15% of the patients could relapse. That's when either chemotherapy or radiation is considered. Patients usually don't get both.
Perfect. So the third question is the case. Actually, 45% of the audience answered seminoma with VIP-VIP.
So this is a question here. One of the key giveaways from this question is that the AFPs are not usually elevated in seminoma. So that is one of the key differentiation between seminoma and non-seminoma here. The answer in this case will be C. Treatment options with BEP is the preferred option here, and also since the patient doesn't have any comorbidities, we could use BEP versus using VIP.
Thank you. Thank you for this explanation, Dr. Rio. Actually, now we can go to the questions shared by the audience. We have actually many questions. We'll start with Dr. Lubna Hussein asked, what is the document for preventing peripheral neuropathy in patients with platinum-based chemotherapy? Or what is the experiences? I think she means, what is the document or the experience for preventing peripheral neuropathy in patients with platinum-based chemotherapy?
As far as like platinum-based, administering cisplatin, like cumulative doses could cause peripheral neuropathy. You have to be touching base with the patient, like what is causing the peripheral neuropathy, signs and symptoms. So explaining as a pharmacist, explain to the patients like what kind of symptoms are to watch out for. A sensitivity to cold, maybe one of them. There could be once this happens, doses could be reduced, and treatment. Sometimes patients are taken off the regimen. Also, medications, at times medications such as gabapentin could be used for the treatment.
Yeah. The second question is from, I hope I can read the name right, Pardeep Kumar. In the second line therapy drugs, how many times we can use these drugs? Like for how many, repetition or cycles?
So it all depends on like if the relapse is like sooner, then we'll go to a third line setting. If the relapse is down the line, it could be reused. Also, these are very toxic drugs we are giving to the patient, so we have to be mindful about that as well.
Perfect. We have also another question. So from your experience with patient and from the risk of fertility, like infertility in testicular cancer and with chemotherapy, what is the procedure for, or like the guidelines for sperm preservation?
So sperm preservation, I didn't actually go into the survivorship part during this presentation. So, sperm preservation is something that should be discussed with the patients before proceeding to orchectomy or surgery. And also the nerve preservation should be done, as I said, should be done in a high volume centers where it is being preserved. So it needs to be offered upfront to the patient so that, sperm, they are having that opportunity to do that sperm preservation before proceeding to surgery. They should be educated that there could be a risk of infertility from doing the surgery as well as receiving this chemotherapy. So, all those discussions should take place before proceeding for surgery.
Yeah, perfect. Actually, one of the last questions about pembrolizumab as a third line, is it a flat dose, like 200 milligrams, or is it weight-based, and is it FDA approved or not, or still not?
That I might have to get back. I think it's not a flat. I think it is a flat dose of either 200 or 400, but I'll have to double check that. It was a small study that was done, so I'm not sure if it's FDA approved, but I can definitely get back on that question.
Yeah. Okay. Perfect. The last question also about pembrolizumab would say the immune-related or immune-mediated nephritis happens. Does it happen frequently with pembrolizumab at that with patients with the third line, or no?
Nephritis, that's a great question, which I'll have to get back to you this time.
Yeah. So as pembrolizumab, this still has like a small data in testicular cancer.
Yeah, I believe the study was in about 12 patients, if I'm not mistaken. But I'll definitely get back on that question.
Yeah. So I think we came up to the end of this webinar. I want really to thank you, Dr. Rio, for this comprehensive presentation. Like it handled everything about testicular cancer management, from surgery to chemotherapy to lines and to even complications and other besides, let's say, what happens with the patients. I also want to thank Dr. Osama Tabara and Dr. Ahmed Abdeldaim and the Oncology organizing team for making this platform available to share our knowledge and expertise. Kindly note our beloved audience that we will be sharing the certificates of attendance in 3 weeks from now. And I encourage you to stay tuned for the coming educational events in March. Thank you for trusting IVPN Oncology Listserv. Thank you for time, and thank you for attending this webinar. Thank you for questions and discussion. Thank you so much, Dr. Rio. Thank you, Fatima, and thank you, Mohammed Tantawi. Have a nice rest of day and rest of evening, and thank you for this amazing webinar. I don't know if Dr. Fatima wants to add anything, but I think I'm going to end this, and have a great time.